Cladribine has had an interesting developmental pathway. They did 2 phase 3 studies some time ago, early in the 2000s, called Oracle and Clarity. One was in clinically isolated syndrome, the other was in relapsing remitting patients, and they were fairly typical studies of the time, but the drug didn't get approved because of safety concerns, especially around malignancies. However, additional data was obtained, not clinical trial data, but additional safety data was obtained, and the company reapplied for approval based on additional safety data and these 2 older studies which succeeded against placebo in decreasing relapse rate. And they got approved, and the approval mentions in the label that there was a risk of malignancy, but it was felt to be an acceptable risk compared to the benefit. And the drug itself, which is dosed orally just for 2 weeks annually, is conveniently dosed because then you don't have to take it again. Interestingly enough, there's some long-term data that looks like there's a prolonged effect even after you stop the drug. Other interesting aspect, even though it has effects primarily on lymphocytes, it didn't cause a lot of significant lymphopenia. In the labeling for cladribine, even though they did a clinically isolated syndrome study, which was Oracle, they did not receive labeling from the FDA to treat clinically isolated syndrome, and I think there was reasons that didn't think the safety justified that.
One long-standing question about fingolimod has been whether a lower dose could be similarly effective and have lower risks. The lowest dose that was studied in the original phase 3 trials was 0.5 milligrams. And although it was found to be effective, it had some safety concerns. And it has left people wondering, might a lower dose be almost or just as effective and have a better safety profile? The ASSESS study compared the standard 0.5 milligram dose of fingolimod with a lower dose 0.25 milligram and an injectable therapy, glatiramer acetate. The trial was double-blinded, so patients didn't know what therapy they would get, and the outcomes were typical of MS trials, looking at annualized relapse rate and new lesions on MRI. Not surprisingly, the 0.5 was found to be more effective than glatiramer acetate, both in annualized relapse rate and in reducing new lesions in MRI. And the 0.25 milligram dose was somewhere in between. So the 0.25 milligram dose wasn't more effective than glatiramer acetate, but it was numerically somewhere between the 0.5 milligram dose and the glatiramer acetate, the glatiramer acetate results. So what this suggests is that probably 0.5 milligrams of fingolimod is the ideal dose, and that going to a lower dose probably, although we're not sure of this, probably does lower the efficacy.
We've been using dimethyl fumarate since 2013. It's been an effective oral therapy. One of the main side effects of that is GI upset, including abdominal pain, nausea, vomiting, and diarrhea. More recently, diroximel fumarate was tested, and it behaves a little differently in the GI tract, but it's converted to monomethyl fumarate, just like dimethyl fumarate is. So the mechanism of action on MS would be the same, but when they did the study of diroximel fumarate, there were fewer GI complications than those taking dimethyl fumarate.